So for those of whom I've not met, I'm Anya Johnstone. I'm the Research Program Administrator for the Department of Family Medicine. So to begin with, I'd just like to acknowledge that McGill is located on land which has long served as a meeting site among Indigenous people, including the Haudenosaunee and Anishinaabe nations, and that McGill honors, recognizes, and respects these nations as the traditional stewards of the lands and waters on which we meet today. With that in mind, I'd like to introduce Dr. Tina Fahim, who's here to present Introduction to Knowledge Translation and its application to primary care research and practice. She's a scientist for the Knowledge Translation Program at St. Michael's in Toronto and leads the team for implementation, evaluation, and sustainability. She's also an assistant professor in the Institute of Health Policy, Management, and Evaluation at the University of Toronto and associate scientist at the Bloomberg School of Public Health of Johns Hopkins University. Dr. Fahim's research focuses on the science and practice of knowledge translation to implement evidence-based interventions at the provider, organization, and health systems levels. So the presentation today will be 30 to 45 minutes, followed by a 10 to 25-minute discussion period. The seminar is also recorded, so if you wish to not be recorded, you can go ahead and turn your video off now. And with that, Dr. Fahim, whenever you're ready.
Maybe I'll just slip in here to just say I'm very excited to welcome you here. Bertrand and I saw Dr. Fahim present at an HIV event, and both of us had the same reaction of, oh, that would be so useful for at the family medicine department. So thank you so much for having accepted the invitation. And now the floor is yours. Thanks.
Thank you so much for having me. Really excited to be with everyone today. And I see a couple familiar faces. I was just saying hi to Roland. A lot of the examples I'm presenting today include work for the Canadian Task Force, which we both supported for a while. So really excited to chat with everybody. So just a couple admin things. So I don't have any conflicts of interest to declare. And I think all of this was covered in the intro. Okay, so what I hope to kind of cover in the next little bit is just an intro to what is knowledge translation, and in particular, how does it relate to some of these other concepts that we're used to hearing, like quality improvement or patient safety. And then once we've kind of made sense of all the terminology, I want to spend a little bit of time about some of the methods. And so if we're trying to implement something, what's the process that we need to follow, and what are some of the considerations in doing so? And then what I hope to kind of leave you with are some practical resources that hopefully could be useful as you're planning any kind of implementation projects in your own practice or in your research. So just to take a step back and kind of situate why talking about knowledge translation, or KT, is important. Some of you may remember this article that came out in 2009 in the CMAJ that called Canada a country of perpetual pilot projects. And essentially what the authors were arguing is that we spend a lot of time and resources conducting research that is not actually resulting in the impact and the outcomes that we'd like to see. And they were arguing that there's actually a lot of research waste that happens. So a few years later, there was a series of articles about research waste in the Lancet, and it kind of shows how the research waste occurs on a spectrum. So starting with like which types of questions we ask, and are we actually asking questions and doing research that's relevant to our patients and relevant to our target populations? When we conduct the research, are we reporting our outcomes in the right way? Are we telling people what worked and what didn't, and where biases may be introduced, so that others can learn from our efforts and then implement the findings in their practice? And are we doing a good job kind of situating ourselves within the existing evidence, implementing based on evidence, and reporting what we're doing so that others can learn from us? And what the authors were arguing is that there's gaps kind of along this pipeline. And so knowledge translation was presented as a potential solution to some of these challenges. And so KT, ironically, like in a term that's trying to implement and be user-friendly, has like the worst jargon ever. And so even in Canada, what was traditionally called knowledge translation for many years is now shifting towards a new term of knowledge mobilization. But essentially what we're talking about is a dynamic and iterative process that includes the synthesis of evidence, the dissemination of evidence, evidence and the implementation of evidence. So really, it's about putting this evidence into action at different levels. And because there are so many terms, you'll find that you can talk to 5 different people and each will have a different sense of what KT is. And so one of the things to keep in mind is that there's many kind of subsets of KT, and I'll show a couple models that may be helpful to kind of situate what it is we're talking about. So when I talk about KT, there's kind of 3 key things that I'm referring to. The first is dissemination. And really, this is just thinking about how do we get our evidence and our knowledge out there. So this could look as simple as kind of disseminating the findings of your single study. So you've written a grant or you've done a trial, and now you're thinking about, where do I publish it? How do I get my key messages out there? Who needs to know about it? It could be disseminating evidence in a situation where you're ready for people to start implementing it. So for example, you've synthesized the evidence, developed a guideline and some tools, and now you're prepping that body of evidence for implementation. Or it could include implementation, right? So going beyond that dissemination of knowledge to actually actively put strategies in place to get that knowledge used. And then finally, whether you're doing dissemination or implementation, it's really important to keep this concept of integrated knowledge translation in mind. And essentially what integrated KT is making sure that anybody who is meant to use the evidence or who is going to implement the evidence or has any kind of stake in the implementation process is involved in your research process. And so really it's doing research with the people who use it. So not just including them as participants, but including them as partners in your project and making sure that our dissemination and implementation efforts are relevant to our knowledge users, whether those be patients or caregivers or providers or health system administrators. And there's evidence to show that this is actually beyond kind of good practice. It actually leads to better outcomes and hopefully more reduced research waste. So by involving knowledge users in our processes, hopefully we are creating more relevant and more applicable research, we're answering the right questions, and we're setting ourselves up for greater implementation success. All right, so one of the things that Alexandra asked me to speak to is kind of like, what is the difference between KT and quality improvement and patient safety? So I'll go through them kind of briefly. So when we talk about knowledge translation, this is really thinking about how do we move evidence into practice. And so it's really centered on evidence. And in the models I'll present, evidence really is the core here. And the goal is to support a lot of kind of clinical outcomes and policy outcomes. So for example, if we have evidence that shows that mobilizing patients in hospital reduces instances of delirium and improves functional capacity, then the implementation of that evidence would really be a KT project. Similarly, quality improvement aims to improve processes and outcomes, but sometimes it's really focused on other types of endpoints. So it's not necessarily to impact a clinical outcome or a policy outcome. It could be things like efficiency, value, patient-centeredness, timeliness. And so here's where you'll see, projects like improving booking systems to optimize hospital capacity and efficiency, for example. So while it may have the goal of improving clinical care, like choosing wisely, which kind of reduces low value practices, it's not just limited to that. It could include a lot of these other process measures as well. And then patient safety refers to the science and the methods of achieving a system of healthcare that is reliable and trustworthy. And the goal of this field is really to minimize adverse events. So for example, using things like reporting systems and checklists in order to reduce adverse events in hospital culture or within surgery. So going through that, you might have thought, well, that they kind of sound kind of similar, and that's because they are. And there's not really clear boundaries between these 3 fields. There's a lot of blurred lines and there's a lot of overlap. And often your projects can include multiple resources and tools across these fields. And often it's unclear whether is this QI, is this KT, and we could be doing things in tandem. So for example, we could use a lot of QI interventions with the goal of improving patient safety, or maybe that's kind of our goal is to improve equity and safety, and we put that under the umbrella of a QI project. And also some of the strategies we might be using could be just as relevant for quality improvement as they are for knowledge translation. So for example, using audit and feedback, well, is that a QI intervention? Is that a KT intervention? The kind of key takeaway here is that the distinguishing feature of KT is that it's centered in evidence. And that's not to say that QI or patient safety can't be centered in evidence, but that's what kind of makes the methods for KT stand out. Having said that, everything I show you in this slide deck can absolutely be used if you're doing a QI project, a patient safety project, a KT project. And again, I would encourage people to kind of get less caught up in the terminology and kind of the specific fields and just think about these tools as a toolkit. And really, we're just regardless of what we're doing, we're trying to implement something to improve patient or system care. And so a lot of these kind of tools, while I'm presenting them from the field of knowledge translation, are absolutely applicable to QI and to patient safety. And I've used them for all three with kind of minimal issues. But that's where you may see like a QI model versus a KT model, and people may ask why you're choosing one over the other. And so I just wanted to kind of take a second to situate that and show that there is overlap across the fields. Okay, so when we talk about KT, we kind of went over this, but essentially we could think about it as a 2x2 table. So there's the dissemination efforts, so getting our knowledge out there, and there's also the implementation efforts, so the active strategies we're using to get the evidence implemented. But within that, we also have the practice of dissemination and implementation and the science. And I'm going to be coming at this lecture really from the practice point of view. So thinking about like, how do we practically use these methods to get evidence into practice? That's not to say that there aren't, lots of others in the field who are working on advancing the science of dissemination. So testing which strategy is optimal to get my findings out there. Should I be using social media, or should I be using print, or should I be using podcasts? And for the implementation side, same thing, like what combination of factors are most likely to bring about the change? These science questions are absolutely things you can embed in your research projects and your research efforts. But what I'm going to kind of focus on today is the practice side of things. So if we have evidence in mind, what are the steps we want to take to get that implemented? But it's all under the umbrella of KT. Okay, so how do we design a KT intervention? So this is the model that I use for any project I'm working on. It's called the Knowledge to Action model. It was created by Graham and Al almost 20 years ago now. And the really nice thing about this model is that once again, it kind of, oh, am I doing those lines? Sorry, I don't know where that's coming from. It really centers evidence at the core of the model. And so in the middle there, we have what's called the knowledge creation funnel. And so this funnel really refers to all of the different types of evidence that we could use and the stages before evidence is ready to be implemented. So we're starting up here with knowledge inquiry, and this is what we kind of do as researchers. So this could be our randomized trials, our observational studies that are really trying to interrogate a subject and ask like what actually works. So our individual studies. From there, we move into knowledge synthesis. So it's really rare that we're going to change our practice or start implementing something based on the finding of a single study. Rather, we want to take time to appraise the totality of the evidence and use knowledge synthesis like systematic reviews and meta-analyses to determine whether or not this is high quality evidence that we should be implementing. From there, we move into kind of the final stage of the funnel before we're ready to start implementing. And this is kind of where we focus on dissemination, is how do I make sense of this evidence to my context, right? And so this is where we start seeing things like guidelines and decision aids, and so and KT tools. So how do we take all this synthesized knowledge that has effect sizes, and how do we turn those into recommendations or key messages for the public and for patients? So as I mentioned, so our program supports work by the Canadian Task Force on Preventive Healthcare, who create preventive health guidelines for Canadians. And one of the guidelines that they were working on was around fragility fractures. So I'll show you kind of the process of how the task force worked through this funnel. So we start by looking at all the different knowledge inquiries out there. So first pulling kind of all the randomized trials to look at, does screening within a certain population actually work, and should we be recommending it? So you're starting with these individual studies. And again, the goal is not to have one single study guide our implementation. Rather, we want to spend time synthesizing that knowledge. And so in this case, the group did a systematic review to look at screening for preventing fractures among a certain population. And here is where, again, we move from kind of the evidence to start thinking about recommendations. And so at this stage is that final piece of the funnel. We're thinking about, okay, how can we turn this into a guideline? And so here's where we have to balance evidence with the values and feasibility as brought up by our knowledge users, is how do we turn this evidence into recommendations of what to do when it comes to screening? And what types of tools and materials can we give in order to facilitate this implementation? So again, it's unlikely that people are just going to kind of read a guideline in their practice. Instead, we want to think about creating decision aids or tools or infographics and really make it easier for people to digest that information. So really kind of using evidence to kind of center our practice and to create these tools in order to prepare us for implementation. And like I mentioned, Roland was working on this, so Roland, please jump in at any time if I miss anything here. So as we're kind of moving, sorry, did you want to go ahead?
I mean, that was a great example, Tina, of how to start with scientific evidence and end up with tools. It actually took years. I think people need to know that. And it's not a simple process, but we could come back to it at some point. I don't know if you're using another example, but that's a good one. And some of the complexity is obviously not captured there, but we could come back to that.
Yeah, no, that's great. And actually, I'm glad you highlighted that, because as a researcher, my bias is often to start with the funnel, right? Because that's what I do every day. We run the trials, we write these reviews, right? But in practice, where you might be starting on this model is actually identifying a problem and then going back to the evidence and saying, okay, I have this problem. What does the evidence tell me? And is this evidence of high enough quality that I could start implementing it? So whether you're actually starting with the problem and then interrogating the evidence, or starting by reviewing the evidence and moving into the recommendations, there really is a strong balancing act of like the art and the science of it all. Like, what does the evidence say? And then how do we weight kind of the values and the complexities of our knowledge users, of our healthcare system, in order to make recommendations of what it is we should be doing? Okay, so as we move out of this funnel, we're really in the end of the dissemination phase, and we need to start asking some of these key questions of, how do I get my research out there? So this is as relevant to disseminating a guideline as it is to disseminating research from your individual studies. And so we want to think about, what are our goals, and why should anybody care? And why should anybody care now? And I'm sure I don't need to tell you, as like primary care clinicians, I'm sure there's like a lot coming at you all the time. But as researchers, we're often like so invested, and like, this iron deficiency problem is like the most important thing. This screening problem is the most important thing. But providers who are expected to implement all these things at once, we have to make a case to them of like why this is important evidence to consider now, and how does that fit into all the other things that they're dealing with. I also want to think about who's our target audience and who's our messenger. And sometimes, as researchers or as the implementation leads, we're actually not the right messengers to get this information out there. And so that requires, again, working with our knowledge users to ask, like, who is best positioned to get this information out there? And then how will we reach our audiences? How will we tailor our key messages? And so, for the task force, something we do all the time is we create tools that are patient facing, which look quite different from the tools that are provider facing. And then you can start thinking about equity too. So like, do I need to translate this tool? Is this tool accessible? And then we want to think about the formats and the modalities that we'll use to disseminate our findings. Okay, so we've made it kind of out of the funnel. We've synthesized our evidence. We have kind of recommendations. So now, what is the steps that we need to take in order to get that evidence implemented? So there's kind of 4 key questions that we want to keep in mind when we're doing implementation. So we're starting with really defining like what is the specific evidence-based practice that we want to implement? Who needs to do something differently? So who needs to change their behavior for this practice to be implemented? Why would these people change their practice or not? And then how can we facilitate implementation of the practice in light of all of these challenges and facilitators? And so I'll give you an example again, kind of with the same guideline. And so our first step is really thinking about what it is we want people to do. And something we often see is people have a goal in mind, but the specific practice has not been honed in on. So I often say, like, if you're stuck in an elevator with somebody and you have like 30 seconds to tell them what to do when that elevator opens, what are you going to message to them? So if you tell them, I want you to reduce fragility fracture risk, they'll walk out of the elevator with kind of no direction, right? And so this is actually really tough because we want to specify exactly what it is we want people to do. So in this case, we wanted clinicians to use a specific tool called the FRAX to assess fragility fracture risk for females age 65 years and older. And we also wanted clinicians to have a shared decision-making conversation with these women to determine kind of the best treatment. So these are these specific evidence-based practices that we would want people to do. We then have to think about, okay, who needs to change their practice here? So obviously, like the primary care clinicians are going to be one of the targets here, but are there subgroups within that that we need to consider? So for example, is the practice for physicians different than the practice for nurses? And are there nuances there that we need to keep in mind? Also, the patients are an active participant in this. So even though they may not be the ones initiating the conversation, they should have a sense of what shared decision making is. They should have a sense to understand what their risk is for fragility fracture or what they could do about it. And then we also want to consider, like, are there other people we need to keep in mind? Are there other health system actors, other guideline developers, other regulators, other policymakers who may have an impact on whether or not we're able to implement these practices? So from there, we want to start thinking about, okay, why would these people change their practice or not? So we want to kind of move to this next question of why would people change or not? And we could figure out the why using theories and frameworks from the implementation science literature. And it's really critical here to use theories and frameworks to interrogate all the reasons why people might be inclined to make a change or not, but then also to use that theory to make sure we're picking the right strategies to address those barriers and mitigate those facilitators. And so this is one theoretical framework that's really commonly used, not just in the KT literature, but sometimes in QI as well. And it's called the COM-B. So it essentially argues that in order for any kind of individual behavior to change, the person needs to have the capability to change, the opportunity to change, and the motivation to change. So I'll just use a really simple example of exercise, right? And so if I'm motivated to exercise and I know how to exercise, but I just like don't have the time to do it, then unless that opportunity is available and unless all 3 items converge, it's unlikely that the behavior is going to be realized. And often what we do as implementers is we guess and we think we know the reason, and then we end up targeting an aspect of the COM-B that's not actually addressing the root of the problem. So for example, if we're thinking about, motivation around screening, if we kind of tell people it's really important that you screen and here's all the evidence and here's your role to play, but they actually just don't know how to use the FRAX tool, then you can motivate them all you want, but they're kind of missing a key aspect of knowledge and capability here. And so using theory really helps us hone in on what aspects of behavior we need to be focusing on to bring about that change. So for the task force work, we actually wrote this paper that looked at our evaluations over time at all of the reasons why people were likely to use guidelines or not. And so just as an example, these are not fully real, but just for illustration purposes, these are some examples of why people would be willing to implement those evidence-based practices that I showed, which again is to use the FRAX tool and then to have shared decision-making conversations. And we can kind of talk to all of our key actors, whether it be providers or patients, and kind of map these back to the COM-B, which will give us more insight on what we need to focus on. So for example, I'm not aware of what this tool is or how it should be used. That tells us we need to kind of, we need to focus on the knowledge and capability portion of the COM-B. I don't have enough time to engage in screening. Well, that really comes down to opportunity and the availability of time. Third, I'm worried that if I only screen based on risk instead of using kind of bone mineral density, that I'm going to miss people at risk of fragility fractures. So this is motivation and worries about unintended harms by following the guideline. We could also ask patients what their concerns are. So I don't know how to broach shared decision making with my clinician or how to bring this up. And just as important as it is to interrogate all the barriers, we should also look at the facilitators. And so often we really focus on what the problems are, but there's a lot of existing things we can put in place to leverage in order to bring about the change. So in this case, we found that people were more likely to use this guideline if it was endorsed by their colleagues. So this was something that we could tap into to really support motivation. Or this perceived perception that shared decision-making tools were actually really effective at having conversations with patients. So again, this brings us back to an opportunity that we could use to leverage implementation. So we can think about the use of theory as really this bridge to help us figure out, okay, here's what I want to implement. Now, how am I going to do it? So the theory is really fleshing out the why people would change or not, and it's the bridge to making sure we're picking the right strategies. So yeah, so 2 steps, again, using theory. First, we want to ask why people would change or not, and then based on what they say, we want to figure out how we could leverage those facilitators and mitigate those barriers. And so this is where the how comes in, and this is where we'll use things like implementation strategies or QI interventions or whatever you want to call them. But essentially, these are methods or techniques that we can use to enhance the adoption of a practice. And once again, there's an art and a science to picking these. So we want our intervention or implementation strategies to be theoretically linked. We want to use the available evidence to tell us kind of what's going to give us the biggest bang for our buck. And we want to work with our knowledge users to make sure that these strategies are actually effective and useful to the people who are meant to use them. So these are some examples of implementation strategies. Again, those who work in patient safety and QI, a lot of these will look very familiar. They include things like audit and feedback, educational meetings, reminders. And the key here again is to make sure that we're picking the right ones for our barriers. And the other thing to keep in mind is that what we see really often kind of in our work is that people kind of hone in on these implementation strategies and often lose sight of the evidence-based practice, right? And so I can't tell you how many times people come and say, I have this app that I really want to implement, and this app is really great for all these following reasons. It has the guidelines embedded, it has all these tools. And we have to take a step back and say, like, what is the outcome here? Is the outcome for people to use the app, or is the outcome to have more guideline concordant screening and more knowledge and less fragility fractures? If the latter is all realized and nobody's using the app, isn't that still a success, right? And that helps us situate that the app is not really what we're trying to implement. We're trying to implement these practices, and the app may be one strategy that we could use. And again, we have to think about, is the app the right strategy? Are we targeting the right aspects of behavior by using this? Or did we become kind of too focused on a strategy and maybe need to zoom out and look at our theory again in order to make sure we're picking the right techniques to bring about change? So for example, we took all of those barriers and facilitators that we identified, and we could link them back to strategies. And I don't have time to get into this today, but really there's kind of 3 considerations. What's the theory? What's the evidence? And what does our target population have to say in order to select these strategies? And I won't leave you hanging. I'll show you a tool we could use at the end to help you as you're picking these. So for the fragility fracture example, so some of the strategies that we recommended could include things like embedding the FRAX tool into the EMR. So that helps with kind of opportunity and reminders. It could be shared decision-making tools and recognizing that these tools will look different for patients versus providers. It could be education materials, use of opinion leaders since social influences were found to be a facilitator. Or it could be kind of restructuring the way that we book clinics to add a few more minutes to have shared decision-making conversations if a patient is of a certain age, for example. So kind of the key takeaway message is that we have to make sure that our implementation strategies match the barriers. And the use of theoretical frameworks is a really fantastic way to help us make that link. And what we want to avoid at all costs is what's called in our field the Islagiat phenomenon. So it seemed like a good idea at the time, right? I thought this app was going to solve the problems. I thought this was a really great education tool, only to realize a few years later that we just contributed to the research waste because we didn't actually interrogate the reasons why behavior was or was not occurring. Okay, so those are kind of the four key questions to keep in mind when implementing is what do we want to do? Who needs to do what differently? Why would people change or not? And then how do we use theory to figure out how we should bring about change based on that why? There are a couple of other key considerations to keep in mind too. So first is we want to keep intersectionality and equity at the forefront of our minds. And this QR code, which I'm happy to share all the resources after, but links you to a page that has a number of intersectionality enhanced frameworks and theories so that as you're kind of interrogating all these barriers and facilitators, you can keep some of these equity considerations in mind. And it also has this workbook that members of our team created. And this really speaks about bias and positionality and helps us kind of recognize, what biases might we be bringing to the project, who are we involving in our work, and who might be left out. And includes kind of these nice one-pagers that you could use as a team before any kind of research project or even within your own practice. And again, the intersectionality component is really critical here. And I'll use breast cancer screening as an example. The researchers that work on breast cancer screening have done an amazing job involving patient partners in a lot of their work. But when we take another kind of look at it, if we look at the patients who are often involved in these studies, they're not representative of who is actually experiencing a lot of the screening gaps. So in Ontario, for example, a lot of the patient partners involved are often white women who are English speaking and highly educated and high socioeconomic status. And when we look at where the gaps are, it's often among newcomer women or those who don't speak English as a first language. And so even though we've included patients, there's one really critical perspective that's missing. And if we don't address the barriers for those people, then it's likely that even though our strategies are, patient informed, they may actually not be addressing those gaps and might actually make them bigger. So again, this is really something that we can apply from inception of our project all through the cycle of implementation. And the other thing we want to keep in mind is evaluation. And again, in practice, this doesn't have to be the most comprehensive randomized trial evaluation, but we want to just keep track of what we're doing and how it's going. And so we want to think about, what is the ultimate outcome that we want to achieve? So in this case, it's guideline concordance screening, it's decreased fractures, it's decreased harms due to screening. So before we kind of get to those measured outcomes, we want to take a few steps back and think about how well are we implementing our evidence-based practice? And if we've created all these strategies, do people actually read our educational materials? Do they like our opinion leaders? And if there's kind of a big disconnect there, that's a really great opportunity for us to make sure that we improve our implementation quality. And then similarly, there's all these mechanisms of change that need to occur before our outcomes get realized. So for implementing something, people are like the outcomes for fragility, fractures are not going to change tomorrow, but what we might start to see is increased knowledge and increased skills about screening, increased awareness and increased intention to screen, increased understanding of patients about shared decision making. And so by evaluating these things, we could understand, okay, we're on the right track to kind of realize our ultimate outcomes, or hey, look, we're not seeing any providers change their intention, or we're not seeing any changes in knowledge. Maybe we need to take a step back and reappraise what it is we're implementing in order to realize the change. Okay, so that's really kind of the material I want to cover. Before I open up for questions, I just wanted to show a couple of resources and some courses we offer if helpful. So one thing that we get a lot is kind of KT folks is people coming to us saying, you know, your field is like full of jargon, it's full of all these theories, models, and frameworks. Like, how do I make sense of all of this? And so we developed this workbook, and the goal of the workbook is really to support those interested in implementation practice. And what it does is guides people through those questions I showed. And it's just a series of worksheets to fill out, like, what do you want to do? Who needs to do it? And then why would they do it or not, and how? And it embeds a lot of these theoretical frameworks and models in the background of the workbook, but it doesn't expect people to be experts to figure out when or how to use them. And it includes this tool that was created by members of our group that helps with that process of moving from why would people change or not to how. And so, for example, if we find, you know, in filling out our worksheet that, you know, physicians don't feel that it's part of their role to screen, they think somebody else should be doing that. It maps us to the types of strategies we could use to bring about change. So for example, if I'm trying to mitigate this kind of challenge, I could consider using these types of interventions. And the workbook really kind of takes you through all the steps so that you can think about why people would change and then what type of strategies you can use. And again, there's really kind of an art and a science to doing this, because as we're picking our strategies, we want to do it in collaboration with our knowledge users who will tell us whether this is usable, acceptable, feasible, and sustainable. And again, this is all open access, so happy to share it. And then just a couple of things that we offer in our program if people are interested in learning more. First is a course on the foundations of knowledge translation. So kind of what I've covered today, but it's a self-directed course that just situates like, what is KT, what are different theories, models, and frameworks, and how do we start thinking about this in our own research? The second is a more intensive course. We just delivered our last iteration, ended yesterday. It's a 4-day course for people who are a lot more interested in these theories, models, and frameworks. So this is a great thing to consider if you're like the KT or QI expert for your clinic, or if you're thinking of doing like hybrid trials or implementation studies and may need to understand a bit more of that theory. It walks you through step by step all of the considerations for doing KT research. And then finally is one that's really centered on dissemination. And this was created especially for people who were writing grants. And for CIHR, you know, there's a section that's like, tell us about your KT plan and what you're going to do. So it's really thinking about how do you communicate your research knowledge? How do you measure your dissemination impact? And the goal is for people to have a ready to use dissemination plan. So again, this one is also self-directed and people can just register and start at any time. Okay, so the bottom line is that knowledge translation, quality improvement, and patient safety have a lot of overlapping concepts, but they are distinct fields. That said, everything that I showed you today can absolutely be applied to QI and patient safety. When doing KT, the distinguishing feature is that we want to start with a strong evidence base. And in the instances where we don't have strong evidence, we want to implement with caution. So maybe we don't kind of scale up across the province. We start slowly and we measure really comprehensively, like what we're doing and how it's going and what the impact is. And we can use theoretically rooted frameworks to figure out barriers and facilitators to change, and also to use it to make sure we're picking the right strategies to mitigate those barriers and leverage the facilitators. And throughout our research cycle, whether it's doing an individual study to doing implementation or evaluation, we want to involve our knowledge users, and we want to keep kind of intersectionality and positionality in mind to be critical about who it is we're bringing to the table and whose needs are being prioritized. And then finally, as much as we can, we want to evaluate everything so that we can learn from our successes and failures, especially in instances where something worked. People are going to ask you, well, what did you do to get it to work? And you want to be able to tell them, here's the strategy I used, here's what went well, here's what didn't. And then on the flip side, if something didn't go well, you could feel more confident to say, maybe this intervention actually doesn't work for these clinical outcomes, not did I just do a really, really bad job implementing it, and that's why I didn't see the outcome. outcomes. So it helps us unpack that black box and make sense of our outcomes, whether they're positive or negative. And that's it. So thank you so much for having me, and happy to take any questions.
Thank you so much. That was a great presentation. Again, maybe we can start with the question by Paula.
Thanks a lot. This is great. I've always been a fan of KT, and you were talking about the evidence base, and you showed Ian Graham's model, which I've often wondered about because it's about implementation essentially of the evidence after knowledge synthesis. But what about end of grant translation after a primary study? And what about I'm saying what about, but it's because these are reflections I've had. I'm interested to hear your perspective about this. So, and also integrated knowledge translation, where maybe we're going to be developing the knowledge, and might be just one little piece of that might then make up some broader evidence base. Because the hierarchy, like I don't do clinical research where the hierarchy of evidence is not something that is so important when I'm not trying to figure out if the intervention is going to save somebody's life or not. If I'm looking at how to modify the organization of health services or whatnot, we can. So I'm just curious to hear your thoughts about where all of this situates, how these different things situate and differentiate.
Yeah, no, great question. So I'll just come back to that model because I find it really helpful just to situate us in where we're at. Give me 1 second, almost there. Okay. So as you're mentioning, so the in terms of integrated knowledge translation, that could really be embedded in any of these stages. So whether you're doing an individual study, like a QI study or a randomized trial, you could think about who should I be kind of collaborating with, and can patients help me pick the right outcomes for my individual study? Can they help me make the recommendations for my guideline, right? So integrated KT really spans every single step of this funnel and of the implementation cycle. The second piece you mentioned is kind of dissemination from individual studies. And I think, again, this is one of the features of KT that slightly distinguishes it from QI, because when we're thinking about KT, yes, if I'm doing an individual study, I want to disseminate it so that other researchers can know what I did and to kind of add to the evidence base. But it's unlikely that kind of my individual study is going to be ready to do implementation, right? And so that's a little bit different than QI, where maybe I don't need like a solid randomized trial to tell me that if I improve my booking systems, I'll improve my wait times, which will kind of get patients in the door faster. However, all the other action implementation steps would still kind of apply to your project, which again is kind of like one of the distinguishing factors of KT and QI here. Yeah, and then the other thing that you mentioned is really kind of starting with evidence versus kind of starting with a problem, and completely agree. So again, in practice, we might not just be like, oh, I did all these trials and then I spent 2 years on a review and then I did a guideline and now I'm ready to tell people about it. It's actually, we start here. And if you look at this model, all the arrows are bidirectional. So it's not that we have to start in the funnel, but we always have to consider like, where does the evidence come in? And in practice, like just like you've highlighted, we're starting in this step of like, I have a problem. Like I'm not seeing the right volume of patients, or like there's a lot of waste, or there's like low value care, or whatever it may be. And that's the opportunity to say, like, is there any evidence to guide my efforts? And even from a QI perspective, are there other QI studies that I can leverage to inform my implementation, right? And so that's really the bridge here that always kind of puts us back into the evidence funnel. And then from there, we can ask those questions of like, okay, what do I need to do? Who needs to change? Why would they change or not? And then how can I get them to change? And so when we teach this course, I often like overlay it with the PDSA cycle to show people like this is very similar, the process, but the thing to keep in mind is like, what's the evidence, who needs to do what, and theory. And I think the KT literature does a really good job kind of emphasizing those components. Does that answer your question?
Yeah, great, thanks.
So I have another question, but before I just want to, so I remember that someone had mentioned that they attended one of the courses offered, and specifically with their research team for their research project to plan their implementation science. Now, can you remember which one of these, was it the 5 for the couple of days? Do you have in mind? I think it was more than 2 feet who told us
I don't
that.
think anybody here was just in our course this week, but maybe a previous iteration.
Yes, yeah, it was a previous, it was Mona Lutfi who told me that.
Okay,
had
okay.
attended.
This course
Was
has
it-
been running, it predates me. So I think they've been running this far longer than I've been part of the program. So might have been before I started in 2019 as
But
well.
which version works well? It's the 4 days or like couple of days, right? Intensive?
Oh yeah, so it really depends on kind of what it is you're trying to do, right? So foundations I often call like the appetizer, the intro, like for people who are like, I hear about KT, but I don't know what it is, and I don't really understand like what are the components. That's really like a short, self-directed overview that's just going to give you an intro. I think even like talks like this, you kind of have a sense of what KT is, and if you're interested in walking away knowing how to do KT. Like I think foundations answers what is KT. The longer course, the 4-day, helps you figure out, okay, how do I do KT? So that's like for people, again, who are interested in implementation studies. I know hybrid trials are a really big thing right now. And there's also within practices and research teams, we're seeing more roles of like knowledge mobilization expert, QI lead, those types of roles. I think this course would be very, very helpful, as well as researchers who are really trying to think about implementing the evidence.
Thanks a lot. No, I really like your presentation because it kind of reminds, I mean, we all do, I think. I'm sure like everyone around like here did at least one project or supervised one project where the objective was to identify the barriers and facilitators of something, right? Like it's a very common objective that comes back. And then what do you do with those? It's
Yeah.
kind of this pile of like, okay, oh, where do we go? So I really like your organized way of like having a structure of placing them and mapping and going forward. So I think this is so useful. And I know that for me, it's going to be the first step, trying to organize the next step that I see instead of just, like next solution. But what do you see is the most common, because I know you've worked with many teams as well. So what do you see is the most common mistakes that research do, either in the doing or the planning of the knowledge translation?
Yeah, I would say there's probably two. The first is like I mentioned, is people who are kind of laser focused on a strategy that they think is so important, and they're focusing on the strategy or the how without really thinking about the evidence. So I can't tell you how many times people are like, look at my app, look at my educational session, look at all these people I've trained, and they have this like really great, innovative, exciting way that they're gonna solve the problem, but they haven't really taken the time to lay out the exact practices that they want people to do, and they haven't gone through the mapping. And so they are targeting something that might not address the issue. When I teach the course, I give like a really, really simple example of like, if I'm a teacher and I find evidence that says like my students should be drinking 8 glasses of water a day, I could create like the coolest app that they have to like tap the water and, you know, it prompts them, it gives them prizes. But if the reason why they're not drinking water is because they don't have time to get to the water fountain on the bottom floor and come back to class in time, it doesn't matter how incredible my app is, it's not actually solving the root of the problem. And I think sometimes because we look at the literature and it suggests all these different strategies, we don't come back to the model and ask like, okay, where am I? And is this the right strategy? And we end up like creating this really fantastic strategy that doesn't actually address a lot of the problem. And that again, kind of results in research waste. And the other thing that I see often is, jumping into the implementation cycle without thinking about what exactly is it that I want people to do. And actually, I learned this the hard way because that's what I did for my PhD. I was trying in my PhD to develop a program to implement multidisciplinary cancer conferences. And I assessed barriers and facilitators, and I was like, why would you attend a conference or not? And it was only like a year in that I was like, wait a minute, like what exactly do I want them to do? Like it's beyond just showing up to this meeting, right? Like, do I want them to use evidence? Do I want them to collaborate in a certain way? And I like asked all these questions, but the specific what was not clarified. And so when I came back to disseminate my research, I had all these reasons of like why physicians attend, why they don't, but I wasn't able to get to the next step to say, okay, here are the specific strategies or tools we need to put in place in order to make sure these practices are evidence-based, are collaborative, are patient-informed, right? And because I didn't take time to specify my what, I again kind of was not fully, well guided in my implementation cycle. And people often think they know what their what is because they have a clear goal or they have a clear practice, but it actually takes a lot of time to specify like what exactly do you want the patient to do? What exactly do you want the provider to do? But it's a really, really critical step to make sure that your implementation is clear and to make sure that when you go through this process, you know what it is you're going to evaluate to determine success. So I would say those two things, like jumping to the how before the what and not having a clear what before you start implementation are probably the two biggest gaps I see.
Thanks a lot. And I think Roland had probably had left for a clinic, but I fully support his idea. I think it's so important to see the perspective of the provider, because it's so true that we receive all these guidelines, all these recommendations, all these things, and it's so not impossible to apply them all. So while each guideline is focusing on one aspect of each patient, so I think having that in mind is so useful.
Totally. Yeah. No, totally. It's so funny because we just finished the course yesterday, and that's like one of the things I left people with. I was like, as researchers, this is going to be the most important topic for you. It's like your whole life. But for providers, this is like one of 100, 200 things they have to consider, which is why it's not just enough to think about the barriers, but to think about the facilitators and to think about sustainability, right? So if all I'm focusing on is fragility fracture, but they have 10 other screening guidelines to implement, how long am I going to be able to keep the attention on fragility before other things get missed, right? And so thinking about the facilitators up front is like, is there a screening program in the office that we can leverage? Is there an educational day that covers multiple things that we could include our materials in? And will I be able to sustain that over time is also really critical. And then you'll only know what those things are by having providers at the table to tell you like, this is a priority, this is not, here's where this fits in or not. So it's really, really critical to kind of step out of the abstract and the research and put on that like practical clinician hat when we're designing these strategies for sure.
Thank you. Now, does anybody else have a comment or question? I don't see hands. So if not, I think I'm just going to thank you so much for this presentation. The recording will be available, and I feel this is something that we may, I find it's going to be a good reference for our students, just to even understand all that. And I think for every researchers, when they have to tackle the dissemination section or the KD section in a grant, often this is where people, oh right, I need an intelligent plan, and I think this is so useful to kind of go back to the concept and everything. Thank you so much.
Yeah, no, my pleasure. And please reach out anytime if anything I could do to support with your projects. And if it's helpful, I'm happy to kind of give all these resources in PDF form so they're available to people. So I'll send that to you after, Anya,
Yes.
and feel free to share.
That'd be great.
Great. Thank you so much for having me. Have a great day and weekend.
Thank you so much, and have a good day, everyone.
Thank you.
Thank you.